In about 1949, a French naval surgeon called Henri Labourite, who is one of the most remarkable people in the history of psychiatry by my estimation, and certainly one of the people I'd like to invite to my fantasy dinner party, which would have to be in another place as he's passed on, discovered a drug which he was actually using to try and see whether he could protect wounded servicemen from surgical shock. He discovered this drug produced a peculiar indifference in his patients. His patients were no longer worried about their surroundings, and the drug became the first. Elaborating on a piece of lateral thinking, thought, well, maybe there are some people who would benefit from being indifferent to their surroundings. What about psychiatric patients who are disturbed by their surroundings? And he had a bit of an upward steep hill to climb in terms of persuading his colleagues to try these drugs on psychiatric patients, but they were tried in the end. This particular drug became known as chlorpromazine, and it was the first antipsychotic drug, and it was the first drug which in some sense seemed to work in terms of the treatment of psychosis or the treatment of severe mental illness. In fact, it was probably the first effective psychiatric drug of any sort whatsoever. Within about 2 years of the first clinical trial of chlorpromazine, it was being widely used in psychiatric clinics throughout the world, and it became the treatment of choice for patients with psychosis. Up to that point, drug companies hadn't thought that there was any kind of mileage, any money to be made out of developing drugs for psychiatric patients. And they suddenly realized that there probably was. And so this led to a flurry of innovation in psychopharmacology, which led to the development of new antipsychotics, and then a class of drugs, the antidepressants. Actually, the first antidepressant was a failed antipsychotic. It was called imipramine, and it was being tested for its antipsychotic properties. It didn't work, but people noticed that patients seemed to be a bit more cheerful on it, and so on. So we end up with a whole raft of psychiatric drugs, which are in use today. And in the era following the development of these drugs, what tended to happen was that the emphasis in psychiatric care was on delivering drug treatments for patients with psychosis. And that remains true today. Now, there are lots of questions which can be asked, in fact, about the effectiveness of these drugs in the long term, and I'll be very happy to take questions about that if people want to discuss it at the end. I think the bottom line is basically they work, but nowhere near as well as people have thought they used to think they work. And in this period, what's tended to happen is psychological therapies have been largely ignored. So what I want to do today is to say, until very recently that is, what I want to do today is take you through the story of the evolution of psychological therapies for psychosis since that time, which has one very important implication for the way we think about mental illness in general. So I'm going to start with the beginnings. This is, for those of you who can see it, is Pilgrim State Hospital, which is was at one time the largest psychiatric hospital in the world. It had 14,000 patients. It's at the end of Long Island. I visited it in the early 1990s when it was almost closed down. There was only 3,000 patients left there. It was almost a small city. It had its own laundry, its own fire and police departments, its own power plants, its own church, cemetery, farm, even had its own station on the Long Island Railway. And this was where most psychiatric patients would spend decades of their lives if they had a severe mental illness in the middle years of the 20th century. What would happen is you'd be admitted to one of these places. With a bit of luck, you might get out. If you got out, that was maybe okay, but if you had another episode and you went in, you'd end up on a long stay ward. There would be 50 patients on the ward. Psychiatrists would come in for an hour a week maybe. These were miserable, dark, dangerous places. There was lots of violence in them, and people lived out their lives there. And it's in this period, with these huge hospitals, of course, it's very difficult to think about how you could deliver psychological treatments for people with psychosis. And there are very few people who are kind of enthusiastic of this. There were a few psychoanalysts. This is Frieda von Reichmann, who was one of the only psychoanalysts at the time who kind of experimented on psychoanalytic treatment for patients with psychosis. But, I mean, nowadays, more recently, people look back at the data from her studies and suggested that her therapy was completely ineffective. Whether or not that was true, what was certainly the case is that psychoanalysis was impractical as a treatment for patients living in these huge institutions because it was just very expensive. You had to see a therapist, a highly trained therapist, once a day for several years. It just couldn't be done. And it's often forgotten that my profession, the profession of clinical psychology, was actually created in this period in order to solve this problem. So there were no clinical psychologists before the Second World War, and it was during the Second World War that some psychologists were inducted into the US Armed Services medical divisions to try and provide psychological treatments for servicemen. And they had no training, they just had to kind of make it up as they went along. But it was actually quite successful, and at the end of the Second World War, in both Britain and the United States, it was decided to formally create a profession of clinical psychology. And in the United States, this was done by the Veterans Administration and the US Public Health Service, cajoling a bunch of academic psychologists to retire to a hotel in Boulder, Colorado, and dream up a curriculum for clinical psychology training. And they sort of did it on the back of an envelope. They weren't clinicians, the people who devised this training. Most of them weren't clinicians. Britain, it happened a little bit more haphazardly with a short course which began at the Institute of Psychiatry in London, where the aim was getting psychologists to test patients and be able to assess their intelligence, personality and stuff like that, but not to do therapy. So what was this new profession going to do in the face of this huge mountain of need in these hospitals? Well, what they did was, what a lot of them did was try to apply science. And remember, these were people who had spent most of their time in universities. They'd been used to doing experiments, actually mainly in those days, animal experiments. They did lots of research on conditioning and learning in dogs and rats and pigeons. And so when they kind of thought, what are we going to do? What they thought of is what they knew. What they knew was how to condition rats, pigeons and dogs. And they developed treatments which were based on those kind of principles. In Britain, they were inspired largely by actually a German emigre psychologist, Hans Eysenck, and they developed treatments for anxiety disorders, which are actually still in use today and still quite effective. But in the United States, a lot of these newly qualified psychologists found themselves in these huge hospitals, and what they knew about was what was called operant conditioning theory. Operant conditioning theory is basically, I mean, I'm being a crude simplification, but it's how you train your dog. Okay? And this led to the development of a new kind of case study where a patient's behavior was recorded in terms of graphs. And psychologists were not really interested in what happened to the patients before they came into hospital, before they became ill. They were just interested in changing behavior. In fact, some of them actually called themselves behavioral engineers, which is an amazingly arrogant term when you think about it. So this is an interesting example. This is from, for those of you who can see this graph, this is a graph of the behavior of a patient called Helen, who was at the Saskatchewan Hospital in Canada. And Helen had a serious psychotic problem. She was highly delusional, and her delusions were all about being raped and having an illegitimate child and men molesting her. It never seemed to occur to the behavioural engineers to inquire whether it could perhaps be true. And oddly enough, because interestingly enough, we now know that actually many patients with psychiatric problems do have histories of childhood trauma. It didn't occur to them to ask this question. This was just delusional behaviour and it had to be eliminated. So they looked around for what was the reinforcer, as it was termed, the reward which this woman was getting. And they thought it was the nurses paying attention to her. So the nurses were instructed not to pay attention to her whenever she talked about these things. And as you can see, this produced an almost miraculous improvement in her delusional behaviour. What happened was the amount of speech that she made about these topics just went down almost to zero, until on the 10th week, unfortunately, an ignorant social worker turns up on the ward and thinks this lady needs a bit of attention and starts listening to a story, whereupon the so-called delusional speech returns. And this was seriously considered as a treatment for severe mental illness, eliminating inappropriate behaviours, as it was called. Now, some of the things which people did in this time were actually, in a way, impressive. So, for example, a common problem you got in these old hospitals was what's called elective mutism. So elective mutism is patients literally stopped talking. They'd been in hospital for decades. They had nothing to talk about. They had nobody they wanted to talk to, so they just stopped. And they would go for years without saying a word. And psychologists would actually reward, first of all, these patients for grunting with sticks of chewing gum. And then, when they were grunting quite well, they'd only get the chewing gum if they actually said something. And crude and simplistic though it may be, actually after a while, a lot of these patients began to speak. I actually saw this happen to a patient in Denbigh Hospital in North Wales when I was a young student. The high water mark of this approach was called the token economy system. What happened in the token economy system was that the nurses on the wards had packets of plastic tokens. And whenever a patient achieved a target behaviour, they were given a plastic token, and later they could exchange these plastic tokens for goodies like cigarettes or sweets or cups of tea. It was an amazing thing to see, actually, because I spent a little bit of time on one of these wards when I was a young student. And actually, highly institutionalized patients who had not been able to look after themselves, their behavior did change. So it wasn't a completely negative sort of, it wasn't all a bad thing. But obviously, we now think of it as simplistic, and we now think of it as, to some extent, unethical. There was a hospital in Nottingham where the psychologist had on his door, comply or complan, a big notice that said comply or complan. That was because if you didn't have tokens, you couldn't buy your lunch, and you had to have this horrible drink called complan instead. So now, excuse me, but I suspect that having lunch is a human right. So, so you can see the way that this kind of approach could be abused. So naturally, it didn't appeal to, although you have to say, returning the speech, getting patients to speak when they haven't spoken for 10 years is no mean trick. But this approach obviously didn't appeal to some psychologists, and an alternative approach was advocated by this chap. And this chap was Carl Rogers. And Carl Rogers, I think, is one of the neglected heroes of psychology, in a way. When I was a trainee clinical psychologist, my some teaching about Carl Rogers went like this. There was a guy called Carl Rogers. He was nice. Now let's go and talk about cognitive behavior therapy. So Rogers was famously nice. He was literally famous for being nice. And he thought that he was a huge optimist about human behavior. And he thought that that you don't change people's behavior by using a technical approach, by using the appliance of science. What really counts is warmth and human relationships. And he had 3 key ideas. First of all, he didn't think psychotherapy should be very directive. The therapist shouldn't tell the patient what to do. He even thought psychoanalysis was too directive. He thought that patients had a capacity to heal themselves. He was a real optimist. If patients were just put in the right circumstances, they would get better. The natural healing process would work. And he came to the conclusion that there were what he called necessary and sufficient conditions for therapy. And these were empathetic understanding. The therapist had to be able to empathize with the patient. What he called congruence, which was some people call genuineness, which is like you can't fake empathy, it's got to be real. The patient will spot it if you're really thinking about your shopping list. And the other is unconditional positive regard. The patient had to be valued by the therapist. And Rogers said if the therapist could provide these conditions, the patient would just get better, basically. And that was all that's required. And he questioned whether a psychological training was necessary. He said he was a psychologist himself. He said being a psychologist is a good thing for many purposes. If you want to do research or so on, doesn't necessarily make you a good therapist. In fact, he'd be happy with thinking there's some people who are just almost born good therapists. So Rogers was actually a believer in research, and he was one of the first people who carried out controlled trials of psychotherapy to find out it was effective. And he decided to carry out, because he was such an optimist, he thought he would carry out a trial of this therapy with patients in these huge hospitals. And it was actually one of the earliest trials of psychological therapies for patients in these huge hospitals. So you have to imagine these warm, empathetic, and optimistic psychologists going into these huge institutions and trying to work with patients who could hardly speak and who couldn't look after themselves. And of course, it turned out to be much more difficult than he expected. And actually, the project was a bit of a disaster, because one of the reasons why it was a disaster was because of the relationships of the people within the project. And particularly, there was a chap called Charles Traux, who fell out with Rogers. And Traux actually stole the data from the project at one point. And at one point, he actually claimed that somebody had broken into his garage and stole the data from him. And it was terrible. And Rogers, because he was such a nice guy, couldn't bring himself to sack Traux. He thought if he just reasoned with Traux, in the end, Traux would become a decent human being. And Rogers later said it was his worst mistake not to fire Traux. Anyway, eventually, 5 years later, they do publish the data. Lawyers were involved in the arguments between different members of the clinical bit of the team to do this, and the results were negative. They didn't actually find anything all that they didn't had a positive effect on the patients. So who was right at this period of the development of psychological therapies? Well, it's easy to think that behaviour therapists were right, because a controlled trial in Illinois of the token economy system showed that it was very effective at getting patients out of hospital in particular. I won't go into details about it, but basically they showed that using this approach was a good way of giving people the skills to get out to a community. So it may be simplistic, it may be unethical in the way it's implemented in some places, but in that particular circumstances, it seemed to be very, very useful. And they showed also convincingly, there's people still arguing about this trial 30 years later, interestingly enough, they showed convincingly that it wasn't the drugs which were actually getting the people out into the community, it was the psychological therapy. But there's a much more interesting story to this, a sort of nuanced story, which involves this chap, Charles Trouts, this is where Trouts gets to bite Rogers back, basically. So Rogers was such an open person. What he did was he believed that one way of doing research on psychotherapy was to actually analyse what happened in the psychotherapy sessions. So what he did was he had all his therapy sessions, his own therapy sessions transcribed, and he would give them to anybody who wanted them. Anybody who wanted to see what Rogers himself did in therapy, they could get transcripts of the therapy, and they were free to analyse them and try and see what the critical ingredients were, which is what Trouts did. And Trouts discovered something really rather remarkable. What happened was that Rogers was not undirective in the way he carried his therapy at all. So if the patient said something very negative about themselves, so it would be something like, well, Dr. Rogers, I just feel there's no hope really in the world. Rogers would just ignore them. If, on the other hand, the patient said something which was optimistic, so it was something like, well, Dr. Rogers, I'm feeling a bit more optimistic today. Maybe I feel that I will one day be able to form a decent relationship and be happy. Rogers would make a nice, warm, empathetic, aha. And what Trouts showed was that Rogers was aha-ing in a very systematic way. Now, I don't think Rogers was aware of this, but basically the accusation was that Rogers was a behaviour therapist on the sly. He was reinforcing patients' positive self-statements. But this is an argument which it turns out could work but two ways, because about 10 years later, two British psychologists, Hall and Baker, John Hall and Roger Baker, had another think about this token economy system. And they thought, you know what? What happens when you don't have a token economy in a hospital? What do the nurses do? Well, what they do is they sit in their nursing office. They do nothing. Basically, they don't interact with the patients. And this is a problem still today, true today. If you go into a lot of psychiatric wards, you'll find there's nothing much therapeutic going on. The nurses are filling in pieces of paper in the office. The patients are languishing in the lounge, waiting for the medication to kick in. So they thought, if the nurses have to run a token economy, they've got to talk to the patients. They've got to actually go out of the office, go up to the patient, hand them a yellow token and say, well done. So what they did was that they trained a group of nurses to just go up to the patients and do the well done bit without the tokens. And at the end of the day, the patients got the tokens in a pile. It was just so that everything else. So the idea was to keep everything the same. And what they found was that it worked just as well. If the nurses went and gave attention to the patients at critical points of the day, the patients did just as well, whether or not they had tokens. And there's a really important moral for this, which applies to psychiatry today, as we'll see in a little bit, which is that empathetic and genuine, although perhaps not entirely unconditional relationships, are probably the most powerful type of reward available to human beings. And that is an important lesson which we need to apply in psychiatry today, and which is still not properly understood. So just moving, this is history, so moving along a bit to how things are, getting to this point to today. Well, behaviour therapy came out of fashion. It became, Alan Belak in the mid-80s described schizophrenia as behaviour therapy's forgotten child. People lost interest in patients with psychosis, and that was largely because patients were living in the community, and you couldn't do behaviour modification with tokens and stuff like that with people living in homes in the community. Rogers himself lost interest. He drifted off into the personal growth movement, running workshops for affluent people in Esalen in California, and never really went back to psychiatric research. And there things would have stayed, apart from developments in Britain in the late 1980s. So at this time, American psychiatry became very, very biological. So there was no interest in developing psychological therapies for people in psychosis. And at the same time, people who had been doing behavior therapy were developing new approaches, particularly a approach called cognitive behavior therapy for people, mainly people with depression and anxiety problems. This chap here is Aaron Beck, who I know quite well, who's one of the all-time greats, I think, in the history of psychiatry and psychology. He's actually a psychiatrist, but he's actually revered by psychologists, probably more than members of his own profession. He's 91 at the moment, and it's an extraordinary meeting because he'll say, his first question will be, Richard, I saw that paper in Archives last week by so-and-so. I think the statistical analysis is a bit suspect. What do you think? So he's completely on the ball. He's an amazing bloke. So he was one of the people who developed what we now call cognitive behavior therapy. And the idea of cognitive behavior therapy is this. The central idea is that people are distressed by the way they interpret the world. And particularly depressed people have a pessimistic view of the world. They see the world as, the world as threatening. They see themselves as failures. They see there's no hope. And the aim of CBT is therefore to help people develop a more optimistic view of the world, a more positive view of the world. And this is done through various different techniques, such as a process of Socratic questioning and dialogue, and also by asking the patient to do experiments to test out their theories and so on. And the essential idea is this. Beck called it collaborative empiricism, but the essential idea is this. We're all scientists. All of us are trying to make sense of the world. Patients are scientists. Sometimes they make sense of the world in a way which is troublesome to them. What we can do is help them find better theories of the world, theories which are more adaptive, but it's collaborative. If you think that CBT is about telling the patient you've got bad thoughts, you need to change them, it's not like that at all. It's working together. It's actually very difficult to do, in my experience, to do effectively. And in the late 1980s and early 1990s, some British psychologists became interested in the idea of applying these techniques to patients who heard voices or who had paranoid delusions and things of that sort. And I won't go into what happened then, but I was around at the time. I was actually involved in this. It was a kind of exciting period in that we had no idea what we were doing, actually. It was kind of, but, you know, the NHS was a little bit more relaxed than it is today, and you could experiment in trying new therapeutic ideas, and people wrote up case studies and so on. And this eventually led to randomized controlled trials. These are big studies where you randomly give people the psychological therapy of interest versus some other therapy or no therapy at all. And the situation we have at the moment is that there's some evidence that CBT can be effective for people who fail to respond to drugs, for people who are at risk of relapsing because they've recovered from an episode but are in danger of relapsing, for patients who are actually in an acute psychotic episode, actually even the first psychotic episode when they're really ill. And recently I've been involved with Toni Morrison in some studies that even try to use this approach to try and prevent psychosis. There is a way, I haven't got time to describe it because I've just been in the 5-minute warning, but there is a way in which you can identify people who are what we call at ultra high risk of having their first psychotic episode. They're beginning to show the first signs, and the idea is if you can get CBT to them beforehand, can you prevent that episode from happening? And there's some evidence some promising evidence about that. We had 2 trials. One was very successful. The other found a significant effect, but it wasn't so large. But you know, there's reason to be optimistic. So this is just to illustrate the sort of thing. This is a study which I was involved in some time ago, which I'm going to come back to. We're still analysing the study. It was a very large study of which we called Socrates. And it was called the Socrates study because Socrates was the first cognitive therapist, according to some people. And it also stands for Study of Cognitive Realignment Therapy in Early Schizophrenia. And the person who thought about acronym was a chap called David Kingdom, who is the world's best acronym inventor. He's a psychiatrist. And I asked David, where did you come up with this? And he said, oh, well, it came to me in a voice while I was stuck in a traffic jam on the M6. Anyway, what you can see here is, so we had patients in Liverpool, Manchester, and Nottingham, and they were given CBT, Rogerian therapy, or nothing. And this is the same time as receiving drugs, and they're in hospital for either the first or second time. In fact, 80% were in hospital for the first time. They were in the middle of a crisis, a psychotic crisis. They were about as ill as you get. I was quite shocked by how ill they were, because I did some of the intake assessments. And you could see these are the symptoms, how severe their symptoms are at the end of 18 months for the 3 different treatments. CBT, supportive counselling, that's Rogerian therapy, versus treatment as usual. And you can see if you look at Liverpool, which I can neither confirm nor deny that I was the head of a Liverpool site, although I have to say it wasn't actually due to me. We just happened to get some really good therapists there. But you can see that the Liverpool patients, CBT patients, do very well. They got less symptoms compared to the supportive counselling, apparently, and particularly compared to a treatment as usual. But the effect isn't so big in the other centres. So there's what we call a centre effect, which is we were disappointed by, but it turns out to be informative. But the other thing about it is when we did the maths on it, when we did the stats, actually CBT did beat treatment as usual. Patients with CBT at 18 months, after only 5 weeks of CBT, which is quite amazing when you think about it, had less symptoms. But so did the patients with supportive counselling who had Rogerian therapy. So where does that take us? Well, there's a couple of things which I want to say. First of all, before we get on to questions, first of all, the current state of affairs is that there are some meta-analyses. These are studies which actually integrate the results of these studies. And what they show is that CBT does work for positive symptoms, that's hearing voices and delusions. But it's really important to emphasize that it's not a panacea, and the effects overall are not massive. Okay. So what we call the effect size is a standard metric for measuring the effect, is about 0.4, which is, you know, it's worth having, but this is not a miracle cure. It's really important to emphasize that. And any CBT therapist who tells you they've got a miracle cure is actually misleading you. So we've got a long way to go. But there's really another important message from this. I'm going to say 5 minutes. A long time ago, there was a chap called Rosenzweig. This is in 1936, and he came up with something which has recently been called, which he called the Dodo-Bird conjecture. And it was he called it the Dodo-Bird conjecture because he took it from Alice in Wonderland, where there's Alice's Adventures in Wonderland, where there's a dodo bird who organises a race which has no particular start, no particular finish, and everybody gets prizes. So the Dodo-Bird conjecture is that everybody's a winner and everybody gets prizes. And what Rosenzweig said is, do you know what? When we look at psychotherapies, they all seem to work a bit. But these therapies are all doing different things, and yet they all seem to work. How could that be? Now, in 1977, 2 statisticians, Smith and Glass, invented this technique, meta-analysis, which allowed them to combine the results for a large number of studies. And the first thing they meta-analysed was psychotherapy for non-psychotic conditions. And they found good news and bad news. The good news was psychotherapy for non-psychotic conditions is highly effective. The effect size is 0.8, which is very, very, very good. The bad news is that there was no evidence whatsoever that any one type of psychotherapy beat any other. So the Dodo-Bird conjecture, according to them, was upheld. Now, if we go back to the recent CBT trials, what do we find? Well, we find that those studies which used supportive counselling of some sort as the control treatment, that supportive counselling turned out to be surprisingly effective. So what's going on? Well, the likely thing which is going on is that there is some common ingredient of psychotherapy. It doesn't matter whether you're a CBT therapist or psychoanalyst. There's something which all of these people do which is a critical factor. And the critical factor is probably establishing a warm therapeutic relationship. Actually, in a way, Rogers was right. And we call this, in the modern terminology, the therapeutic alliance. The affectional bond between the patient and the therapist and their shared willingness to work towards common goals. An extreme version of this theory is put forward by a chap called Bruce Wampold, who says there are only three ingredients for psychotherapy to be effective. The patient must have a theory what works, the therapist must have a theory about what works, and the 2 theories must be the same. Wampold would say, if they both thought sunbathing would work, it'll work. I think that's a bit too far. I think it is, this therapeutic alliance thing is a good thing. Now, it's obviously likely to be an important factor. Now, I'm going to stop rolling through slides here. I'm just going to finish by telling you some work which one of my PhD students, Lucy Goldsmith, is actually a genuine rocket scientist. She has a first in physics and a first in psychology, has been working on the therapeutic alliance in that Socrates study I mentioned before. We knew in that study that the therapeutic alliance predicted whether or not patients got better. We asked patients about therapeutic alliance at the 4th session. But the trouble is, what you don't know, turns out there's a fundamental problem in statistics which until recently had never been solved. to do with this, which is what you don't know is whether there was something which caused patients to get better and also caused them to like their therapist, but liking the therapist wasn't part of the cause of getting better. Do you see what I mean? So, it looks like this, but it could be that was what we call an unmeasured confounder. And that could be something to do with the patient. It could be anything. It could be something we haven't thought to measure. It could be the colour of the wallpaper in the room in which the therapy takes part. Maybe if it's green wallpaper, the patient will like the therapist and they will get better. Who knows? Now, without going into detail about this, Lucy's been working with a statistician called Graham Dunn, and they found a way of solving this problem. And they found a way of analysing this data which takes into account not only all the things we've measured, but anything we haven't measured, which is kind of magic. And if people want to know how it did, I cannot actually come up with a sort of explanation. But what they found is this, which is really interesting. They found that patients with a good therapeutic alliance, the number of sessions they have determines how well they get. In other words, if there's a good therapeutic alliance, the more therapy, the better people get. So the therapeutic alliance is causing people to get better. It's a vital ingredient. But also, really interesting, for patients who had a poor therapeutic alliance, the more sessions they had, the worse off they ended. So having a poor relationship with the patient actually was poisonous. It actually harmed the patient. So the bottom line is, so basically, it turns out there are lots of other studies which show that this therapeutic alliance is important in psychological therapies. They don't use this fancy statistical technique which we've now got, which shows that therapeutic alliance has a causal role, but nonetheless there's lots of other evidence which shows that therapeutic alliance affects how people do. And if we've even shown in one study that the therapeutic alliance affects how people respond to psychiatric drugs, which is quite amazing. So, so it's what I call a universal good. And the essential point, the conclusion I want to reach is this, which is that, I won't do it. One problem we have in psychiatry today is actually a lot of people are really bad at forming a therapeutic alliance. So a vivid illustration of this is a study carried out by a friend of mine, Stefan Prieb, who's a psychiatrist, professor of psychiatry at Bart's Hospital. And he filmed British psychiatrists at work interviewing their patients. And you have to think about this. They agreed to be filmed, so they must have thought they were doing a good job. They knew they were being filmed, so they must have thought they were doing as best as they could on that particular day. And Stefan has described, the paper's published in The Lancet a few years ago. Stefan described the results, I think, fairly frightening. But a lot of times what was happening is you're having two conversations which were going in parallel but not engaging with each other. The conversation with the patient was going, "Doctor, why have I got this problem? What does it mean? How have I got into the situation?" The conversation with the doctor was, "Will you take the drugs?" Go on, take the drugs. Do you take the drugs? And it would go on until somebody, usually the patient, gave up. So the moral of a story is that, in a way, Carl Rogers was right, that there is one thing which we could do to improve psychiatric services almost overnight, really. And it doesn't involve necessarily spending huge amounts of money. It doesn't involve fancy technologies. It doesn't involve massive innovations, even in therapy or whatever. What we've got to do is to get everybody to have a good relationship with the patient. Doctors, psychologists, some psychologists are not good at forming good therapeutic relationships. It's not just the criticism of doctors. Nurses, the person who comes onto the ward who does the cleaning. All of them have to be selected or encouraged to form good relationships with patients. The bottom line is that what the science is telling us today is that actually one of the most powerful interventions we have in helping with people with severe mental illness is kindness. And actually that's what we need to know, where we need to find ways of injecting kindness into our psychiatric services. If we do that, we will get much better services. I better stop at that point.
We've only got 5 minutes for questions, so if they could be quick. You had your hand up first. Sorry, I'm going to go around to avoid the camera. And hold the microphone nice and close.
Would you have any opinion about people with severe mental illness having to take responsibility for their own actions, their behaviour, and when they get an insight into that, they can make some progress in recovery?
Well, that's a big question. Yeah, so obviously, so one aspect of that is to do with what we call self-efficacy, about feeling in control of your life. And one of the things we found actually in some studies we haven't published yet is that if you ask patients about what would count as a recovery from them, self-efficacy comes out very large in that. They're actually not all that bothered about symptoms, a lot of patients. They're more bothered about feeling a sense of self-worth and a sense of empowerment so that they can actually navigate their lives, they can direct their lives. So part of the aim of psychological therapy has to be, I think, actually helping people to reach that point where they feel, yeah, I guess you could say responsible for their own actions and having insight. But you're not going to bring those things out by just sticking people in the ward and giving them a tablet, even if a tablet is helpful in other ways.
I just wondered, to what extent do you think a successful therapeutic relationship depends upon mutual trust and the willingness to develop a relationship of mutual trust between therapist and patient? And conversely, do you think that a paternalistic attitude of manipulation on the part of a therapist can lead to paranoid symptoms, can increase paranoid symptoms?
I think you're almost certainly right. Basically, I don't believe you can have a therapeutic relationship without trust. And actually, it's kind of difficult to establish that with people with very severe mental illness, or some people find it very difficult, actually. There's a certain sort of mindset which you have to have towards the patient. If you do, there is a bad way and a good way of doing CBT. If you do CBT in the sort of, right, you've got dysfunctional thoughts, I'm going to give you some better thoughts, that is not going to get anywhere. It's not going to help anybody. It's like having an argument with somebody. When was the last time you had a political argument with somebody and the person at the end of the argument went, God, you're so right. Oh, how could I have been so stupid? It's obviously not going to work. What you have to do is form a collaborative relationship where you're working together, and that does require trust. And I agree, a paternalistic attitude is actually one which is not going to foster trust. And the big problem with psychiatry, one of the big problems in psychiatry today is it's highly paternalistic. So, and it's been made more paternalistic by recent legislation, in fact. So the fact that it's now possible to give patients community treatment orders, for example, where they are legally required to take medication even when well in the community, on the fear that they will become unwell if they don't. That's how you can't get more paternalistic than that.
Another question over here.
Oh, hello, I'm Millie Key from April Charity, and my daughter was at home psychotic before I knew anything about psychology or psychiatry or what harm the drugs were doing. And the psychiatrist refused to let her see a psychologist. The first episode was 85, so you'll understand. Well, later when I started the charity, I had a conference and I invited Dorothy Rowe,
yes,
who's an expert in depression. And she said one of the most important things is a therapeutic relationship with anyone. So what I want to ask you is, can a family help a person who's psychotic if the psychiatrist is refusing to let the person go to see a psychologist?
Well, first of all, I think it's really important to emphasise that if the therapeutic relationship, as I believe, is a critical ingredient, psychologists are not always necessarily, I don't think you should look at clinical psychologists and say, we're a fantastic profession, we're necessarily wonderful at doing this and other people are not. There are plenty of nurses who who are good at this as well, for example, and quite a lot of psychiatrists. So it's more to do, I'm sort of doing myself out of a job in a way, but I don't want you to think that there is this one group of experts in the therapeutic relationship. That's not true. There are, I think it's terrible that a psychiatrist could actually take the position that you've described, and it's not an uncommon experience in my view, in my experience. And, how is that going to be positive for the patient? Whether or not families can help, it turns out to be a rather fraught issue, because what we do know is that family atmosphere has a big effect on whether or not people recover. And this is a well-replicated finding. It's one of the best replicated findings in psychiatry. So basically, the situation is this. In Britain, what would tend to happen is you have a young person who has a breakdown, and they end up back in for family home after they've been through a period in hospital very often. And the trouble is that creates a kind of pressure cooker situation for a lot of families. And the families, often it's the most loving families, they're very worried about whether or not the patient will recover or not. They become very anxious. They often feel very guilty. What have I done to cause this? And so on. And that can come out in various different ways. One of the ways it can come out is anger, which is expressed at sometimes towards the patient. And the other way it can come out is excessive overprotectiveness. And the sad thing is we know that actually in the long term that those characteristics in families tend to make recovery less possible. So the ideal approach of and it's very, very difficult for families to do this. And this is not a criticism of families when they can't do it. So as I say, it's most loving families who find this often difficult. But the ideal approach is that if you have the misfortune to have a son or a daughter who has a psychotic episode, had a psychotic episode and returns to home, is to be sort of pretty laid back about it, actually. It's always...
At the beginning, when you feel they're becoming paranoid, that's the time when surely the family can be so...
I think you just have to provide a place of safety. I think you have to provide sympathy and you have to provide support, but you don't think directing or trying to be a therapist yourself will work. I think that's actually quite dangerous. It's a sort of slightly distant form of caring, which seems to be most effective from a family point of view. And there is a type of psychological treatment which is aimed at helping families achieve that and providing support for families. It's called behaviour family therapy. And it is recommended in nice guidelines, but it's not widely available, unfortunately. But it's about giving families support. And one of the things I always look at when I'm talking to families of patients who have a diagnosis of psychosis is I focus on one of the things is the extent to which the mum and dad are looking after themselves. Because often they make huge sacrifices. They're trying to protect the child, and they forget about their own mental and physical health often. And then that makes things worse. Everything becomes too stressful. So it's important that there is an approach that which families can take, but it's not easy to achieve, and it involves, paradoxically, not trying too hard.